Welcome everyone. It's always a treat to be here, and we're excited to bring you another installation of the Holistic series, which we're going to focus on some integrative medicine aspects of how you can approach your Parkinson's disease. It's with great pleasure that I introduce a close friend and colleague, Laurie Mischley, today. She's joining us from Seattle, and she'll be telling us a little bit about her background as a naturopathic physician. She's very diversely trained. She also has a PhD, an MPH. She's got a lot of degrees and a lot of knowledge, and it's been an amazing collaboration that we've had together, trying to approach Parkinson's patients with a bit of a different twist. And so she'll be sharing some of her thoughts and ideas, and hopefully opening your mind a little bit to some of the naturopathic philosophies, and also you can learn a little bit about her approach with some of the research that she's doing to try to understand what helps and hinders our Parkinson's patients with their lifestyle. So with that, I'm going to hand it over to Laurie, and she's going to present some slides for the first maybe 20 minutes or so. Then we're going to open it up. I'm going to ask her a few questions, and then we'll open up to questions from our audience as well if we have some time. Okay, thanks, Laurie.
Great. Thank you for the invitation to be here. This is obviously fun to both be working with you and to have this many people interested in complementary, alternative, and holistic medicine. So I'm going to go through the slides fairly. How do I make my slides advance? They're not, arrow is not working. Oh, there I see. Maybe there. Okay. So I think these slides will be available afterwards. These are some of my disclosures, foundations I consult for, research funding, things like that. So let me just start by talking about what a naturopathic physician is. There are 4 naturopathic medical schools in the United States and 2 in Canada, and they are post-baccalaureate 4-year medical schools. So the first 2 years are very, very similar to conventional medical schools, same textbooks. We even had a lot of the same teachers that they had at University of Washington. Where things got very different were during the last 2 clinical years, where the conventional docs did a lot of rotations and went on to do residencies. We kind of spent those last 2 years talking about the relationship between gut and immune system, and, you know, jack of all trades, master of none. We learned herbal medicine, traditional Chinese medicine, chiropractic adjustments, while doing pharmaceuticals and minor surgery. And so the program is designed to be eclectic. What they're trying to do is take the best of all these different schools of thought through history and kind of make one package of clinical doctorate in complementary and integrative medicine. So I will say from the get-go that my naturopathic colleagues are often very critical of the degree to which I have gone to the other side. I've been called a green MD. I've sold out to the conventional side. My conventional colleagues think I'm alternative and wacky. I mean, I don't really fit in either group. I think I'm a little left of right and right of left. And so I'm not really sure what camp I belong in. But I will say that one of the big issues with naturopathic medicine is there's very little training in neurology, and specialization is largely discouraged. And so when I kind of came into medicine knowing I wanted to work with the brain and brain health, and there was no opportunity to do that. So I had to supplement my education. So after 10 years of practice, I had a practice that was essentially entirely nutritional neurology based, but most of my patients had multiple sclerosis. I had a lot of patients with developmental disabilities, ALS, epilepsy, stuff like that. And then I got an award, an NIH award, to leave practice and go into research. And they let me keep 1 day a week in practice. But for the years 2010 to 2015, my full-time job was essentially to learn how to become learned in research. Right? Like I had to go and infiltrate the conventional community and learn the ways of the conventional methodology, right? And so during those 5 years, my job was to go do rotations with local movement disorder doctors, do grand rounds at University of Washington Neurology Department. I had to go to the annual Movement Disorder Conference and American Academy of Neurology conferences. During that 5-year period, I got a master's in public health and epidemiology, and my thesis was on lithium deficiency in Parkinson's. And I got a PhD in nutrition. My dissertation was on glutathione deficiency in Parkinson's disease. And during that time, I did a double-blind placebo-controlled trial of intranasal glutathione in Parkinson's disease. And so that was kind of my way of getting caught up to a lot of what I didn't learn in my naturopathic program. I think I feel really strongly that naturopathic and alternative medicine docs are very, very poorly trained in conventional neurology. And I think a lot of neurologists are poorly trained in nutritional medicine and complementary and alternative medicines. And my goal is really to help bridge that gap and get the sides talking to one another a little. So if I could just kind of sum up my goals with my career, it's really to kind of unpack this idea that in Parkinson's disease, there are conditionally essential nutrients. We know that pregnant women need more folic acid. We know that burn victims need more protein. We know that smokers need more vitamin C. It only makes sense that if you are dealing with a chronic degenerative stressful disease that you might have some unique nutritional requirements. What a 75-year-old person with Parkinson's needs is probably not the same thing that a young, healthy 25-year-old needs. And so the goal, when the Institute of Medicine and the government makes these how much nutrition is enough sort of recommendations, their opinion is, if there are unique nutritional requirements to people with Parkinson's, that is up to the people who work with Parkinson's to figure that out. The government can't be responsible for figuring out what every single disease needs. And so I've kind of taken that challenge to say, let me spend my career trying to figure out what are the unique nutritional requirements of people with Parkinson's, if any. So the first thing that I published, I'm just going to do a little snapshot of some of the ground I've covered over the years. One of my first publications was in 2012. I looked at, I don't know what it says here, 25 people with Parkinson's, and we compared them to about 100 people who were healthy controls. And we showed that people with Parkinson's were statistically more likely to be walking around with a coenzyme Q10 deficiency. And so it wasn't an intervention trial. We didn't show that giving CoQ10 works. But I will say, I do wonder if the CoQ10 trials that have been done would have gotten a different result if we only did those trials on the people who were CoQ10 deficient, right? Like one of the things that I think one of the problems in how those original studies were done is they treat everybody the same. And giving vitamin C to somebody who has scurvy is going to get you different results than giving vitamin C to somebody who doesn't have scurvy. And so the same kind of idea applies. What if we just gave CoQ10 to the people with low CoQ10? Would we have gotten different results? And I don't know what the answer to that is, but I know that one of the questions that comes is, well, didn't the CoQ10 trial already fail? And so it's just an idea there. I said this earlier, but my master's work was on lithium deficiency. About 20 years ago, I learned that, so I think it's pretty neat how few people understand that lithium is a required nutrient. Just like the human body needs sodium, potassium, magnesium, calcium, so does every cell need lithium. We cannot make our own lithium. The human body requires it. And neurons, brain cells, need a lot more lithium than most other body parts. And so I was fascinated by some old work that's maybe 20, 30 years old now that showed the lower the lithium in the water supply around Texas, the higher the rates of psychosis, violent crime, addiction, some impulse control disorders. And so when it was time for me to do my thesis, I studied the frequency of lithium deficiency in my patient population. And we found that people with Parkinson's were 74 times more likely to have undetectable levels of lithium. Interestingly enough, hair is the only way to measure lithium status of the body. So that's something that gets a lot of eyebrows raised. Patients will walk into their conventional doc's office with a hair test. And I think right away, doctors assume I'm testing for heavy metals and things like that. And that's not really what I'm doing at all. Hair, the inch closest to the scalp, is the gold standard for how one finds out their lithium status. It's the only way to measure it. And so part of my initial workup is I measure people's lithium levels. If they're not low, I don't recommend supplementation. If they are, I do. Since I published this, there's been this really neat paper. There's an article in the New York Times on lithium. I think is very user-friendly for people who are curious about this. And there was another study that just came out, I think it was in Finland last year, that showed the lower the lithium in the water supply, the higher the rates of Alzheimer's in that community. So I'm pretty fascinated with this idea that maybe humans just aren't getting enough lithium. I think the closest analogy we have there is iodine. There isn't a Minerals are unevenly distributed in the Earth's crust. And so some regions don't have enough iodine, so we iodize salt. The same idea is that in places throughout the US and around the world, there isn't enough lithium in the groundwater. And so maybe we should be finding some way to fortify people's lithium status. Glutathione has kind of been my baby for the last 10 years. The first time people talked about this was 1982, was the first publication that suggested could Parkinson's disease be caused in part or entirely from a glutathione deficiency? I would argue it's in part, not entirely. But we've done several autopsies on people with Parkinson's disease, and pretty consistently we see that the brain, the substantia nigra of people with Parkinson's is about 40% depleted in glutathione. So everybody decreases with age. A 60-year-old is already about 30% lower than a 20-year-old. But even compared to a healthy 60-year-old, people with Parkinson's are about 40% lower than that. And glutathione deficiency comes before you lose neurons, before dopamine deficiency, before mitochondrial dysfunction. And so it kind of suggests that this is one of the earlier dominoes in the cascade. And so people have been working on studies and ways to boost glutathione since the 80s. So there was, I don't know if you remember, but probably 15 years ago, patients, David Perlmutter is an MD in Florida, had a website called renegadeneurologist.com, and he posted a video about how people would get intravenous glutathione and have this miraculous response. And so I literally had people lined up outside my office looking for an IV glutathione, and I just felt like it was $100 a shot. It was really hard to ask people with a movement disorder to come in 3 times a week. And so I started looking for alternative ways to get glutathione in. And I started studying intranasal glutathione, a nasal spray, kind of like an Afrin bottle. And so what we did is we took 15, this was a Michael J. Fox funded study. We put 15 people with Parkinson's disease in the MRI machine and had them squirt this glutathione up their nose. And what we showed is that we boosted brain levels of glutathione by 240%. Over the 45 minutes that followed. And so 99% of all CNS drugs fail because the drug never reaches the brain. So this is actually a huge hurdle jumped to be able to say that we now know that intranasal glutathione does in fact reach the brain. In the studies, we've done 2 studies, double-blind placebo-controlled, where we give placebo low dose, high dose, and I'll show you the results of those in a minute. But there were a couple things. This person happened to be dose arm of glutathione, and there are some things that just aren't captured in the UPDRS and the outcome measures that we use in trials. And I find this a fascinating example. This woman was randomized to the high dose glutathione arm. She was using 200 milligrams 3 times a day of the intranasal glutathione. And you can see, we asked, are you noticing anything? And she writes, handwriting better. A week later, 3 days later, handwriting better, handwriting better. You can see her handwriting getting better, but on this scale, her score didn't change. So, according to the numbers, this was a failed, she did not improve. According to her journal entries, she did, right? And so I just wanted to point this out because these are some of the reasons it's so hard to do research in Parkinson's, is this lack of really reliable good scales. So here are the 4 studies that have been done in administering glutathione to people with Parkinson's disease. You can see, I don't know if you can see my arrow, but that first one shows, that second tremor line shows a decrease in tremor following IV glutathione. There was a study done in Florida that showed a little teeny hint of an improvement. It wasn't powered for efficacy. They were just looking to see, is it safe and tolerable? And they said, yes, it was. And then my 2 studies that showed that the first study showed that the glutathione arm was definitely better than the placebo. Where we ran into problems was the second study, where we said in a dream world, the glutathione would result in a 4 to 5 point improvement in Parkinson's symptom score. We got our 4 to 5 point improvement, just like we were hoping, but in the second study, now the placebo group got a huge amount of improvement. And we're a little stuck. There's so much ritual, and like you take the glutathione out of the refrigerator, you put the cap on, you lay down, you snort it. There's so much ritual associated with it. And by the time we did the second study, there was so much enthusiasm in the community about it that we got this super, super strong improvement in even the group that got saline. And so we haven't really figured out a good way to do this study better in the future so that we can move on from the placebo, find a better placebo. So the other thing, because people start talking about nutrition and right away they think I study food, and I really don't. I'm not a dietitian. I don't cook well. I'm not a good person to kind of guide you on dietary choices, but I do like to study the epidemiology of what foods are people eating that put them at risk of getting disease and progressing. It drives me nuts that we have now done about 6 to 8 different studies where we follow people over the course of 30, 40 years and ask, are there any foods people are eating early in their life that increase or decrease the risk of Parkinson's? And we've done that study and we keep coming up with consistent results. It drives me nuts that we don't use these results. I mean, nobody's primary care doctor told them in their 20s, hey, if you eat a whole bunch of vegetables, fruits, beans, coffee, you're less likely to get Parkinson's. Hey, you should really limit dairy, red meat, refined carbs because it increases your risk of Parkinson's. So one of my pet peeves is that we do all this research, but there's this huge barrier to implementing it and getting doctors to start talking to patients about the results that we're finding. If we know these things increase or decrease risk, why are we not starting to apply some of it? This is a paper I recently wrote on nutrition and malnutrition and Parkinson's non-motor symptoms. So I just want to say that this publication is available online, but the people with Parkinson's with the greatest degree of malnourishment are also more likely to have depression, anxiety, dementia, dystonia, and constipation. And so what is the chicken or the egg? We don't know, but I do think that malnutrition plays a pretty pivotal role in non-motor symptoms about Parkinson's. So what really all of the people watching here today really care about is not how I got here, but what can I do from this point moving forward? And so I already vented a little bit about the poor outcome measures that we have in trials. And so one of the things that I wanted to do is kind of find a better outcome measure. And so my slides are tattered. Let me just say what this is. This is an application of the new outcome measure. And so what this says, so one of the things that I like to point out is that when you ask a doctor what are the symptoms of Parkinson's, they will often say tremor, rigidity, hunched posture, slowness. When we asked 2,000 patients with Parkinson's about the symptoms of Parkinson, when we asked 2,000 patients about symptoms, you get a very different answer. The most common symptoms reported are fatigue, impaired handwriting, and loss of smell, followed by memory impairment, muscle pain, daytime sleepiness. And so again, my goal here is just to open this conversation. I think Parkinson's for the last couple hundred years has largely been defined by what the physician can see, not what the patient is experiencing. And I think we're seeing a huge kind of trend away towards patient-centered care, which I'm excited about. But I think it is through meetings like this where the patients start to feel more and more empowered and can go into their doctor with a list of, I don't care what you can see, these are my symptoms. Let's talk about urinary problems. Let's talk about sleep. So to better get at that, what we did is we created a patient-centered rating scale. Every one of you can get your score for free. At the end of this slideshow, I have some references on there. But basically, it takes about 5 minutes, and you go through a list of 33 symptoms, and you just kind of, if you don't have the symptom at all, you put the slider bar to the left. If the symptom is really severe, you put it to the right. And you can just kind of eyeball where the numbers are. But we wanted to create a scale that reflected the patient experience, that it correlated with quality of life, And obviously, we want it to correlate with the other measures that doctors have been using, researchers have been using over the years. So we did that. The reference is on here if you want to go look at it, but we showed that the scale that we created correlates with year since diagnosis and all the outcome measures that we use in our clinical trials. And even more importantly, what we showed is this new rating scale correlates with quality of life. The higher your score, the lower your mental health, social satisfaction, physical health, and overall global quality of life. So with that, now that we had a scale that kind of met our needs, what we did is kind of made this spreadsheet, and the way the scale pans out is when we overlap it with this idea of quality of life, scores below 500 largely reflect people who say their quality of life is excellent. 500 to 1,000, quality of life is good. And right around year 10, that blue line through the center is on average the rate of progression that people experience. So most people the average person at diagnosis has a score of about 580, and it gets worse at about 40 points per year. So right around year 10, where people cross that line of 1,000, is when, you know, I'd say there is a notable, like, hey, time to change my approach here. So, but the other thing I want to point out is every one of these dots is a real person. In research, we call this a tremendous amount of heterogeneity. This is all over the map. There are people who are water skiing and hardly have any symptoms 20 years after diagnosis. And there are other people who are in a wheelchair 3 years after diagnosis. The diversity of this disease is incredible. And so what I wanted to do is use the diversity to my advantage, right? And so what I wanted to do is study who are these people who are doing so incredibly well, and what are they doing differently than the people who are doing poorly? We don't know what's cause and effect, but if you learned that every person who, that I just wanted to study the people who are doing well, and it seemed like a reasonable place to start for people who are trying themselves to do well over time. So again, we can't say what's cause and effect. So an example of this is organic. We ask a question about, we have a true false section of this survey, and we make this statement: I try to eat organically grown foods when possible. No question about it. People who say yes to that statement are progressing slower than people who don't try to eat organic. Doesn't say you have to eat organic all the time, and I'm not even sure that the pesticides are accelerating progression, but it does tell me that people who are going out of their way to be thoughtful about what they're eating, food conscious, overall are doing better. So some of the stuff, it might not be about what we're asking about, but reflect a personality trait, something else about the behavior. Same thing with buying local, shopping organic. We have another statement on there that says, I buy food from local farmers, such as co-ops and farmers markets. People who say true to that statement are doing better over time. We are talking about a different population of people who wake up on Saturday and get their little wicker basket to go to their local farmer's market. I don't think that there's something horrible about grocery store produce that's causing a problem. But I do think this speaks to the thoughtfulness when people are very thoughtful about where their food is coming from and who's growing it and what is being sprayed on it. People who have that mindset are clearly doing better. So here's the punchline. Our data, very clearly, everything on here is statistically significant for those of you who care about the statistics. But what we can say with quite a bit of confidence are the people who are eating the most fresh vegetables, fresh fruit, nuts and seeds, non-fried fish, olive oil, coconut oil, wine, spices, fresh herbs, and green tea are doing the best over time. These foods are associated with the slowest rates of progression. And the people who are eating the most red meat, dairy, chicken, pork, fried foods, soda, canned fruits, canned vegetables, and pasta are having the fastest rate of progression. I'm just the messenger. There are going to be a whole bunch of questions about, but my dairy's organic, and what about my this and that? And the answer is we don't know. I'm just telling you, when we crunch the code and we say, what are the people who are the fast progressors doing differently than the slow progressors? This is largely what the fast progressors are eating. And it's dose dependent. People who eat dairy twice a day are progressing faster than people who eat dairy twice a week, right? And so we're trying to figure out what that is, but this is kind of the research that we have right now. The reason I have a question mark next to pasta, I have question marks next, I mean, there are a couple of these things I don't fully understand, but the thing about pasta is that bread was not at all associated with faster progression. And as I've been soliciting feedback from my colleagues about why pasta but not bread, what has been coming up, I like the idea of this, is that it actually isn't about the wheat. It is that pasta is, people put canned tomatoes and cheese on pasta. And so pasta could be a delivery system for some other stuff that's coming in. It might not be that pasta itself is bad. And so that's the problem with epidemiologic research. I mean, we're studying large populations. And so I can't really tell you why any of this stuff is what it is, but I can say this is what the trend that we're seeing. This is kind of big data. The other thing that I think is fascinating is that not all nutrients are food. Just like you get sunlight, vitamin D from sunlight, social health should really be considered a nutrient. We're looking at hundreds of different variables linked to rate of Parkinson's progression. And what we are seeing is that the #1 predictor of how fast, whether or not the fastest rate of progression comes from people who say, I am lonely. People who say they are lonely are doing worse than people who exercise 7 days a week are doing better. I mean, that just to kind of wrap your head around that. That's why I think these gatherings, you know, I love that this is an internet-based support group kind of, right? So people in rural communities can feel a sense of tapped into a larger community, a sense of connection. But if you can get 1 or 2 take-homes from this talk, it's really just the way I'm telling you to go eat your vegetables and exercise, so am I telling you to leave your comfort zone, go make a friend, reach out to somebody you wouldn't otherwise have reached out to, go help a neighbor. This isn't always about you getting help, go help somebody else. I have a patient who really isolated, has no friends, but 3 days a week he goes to the local elementary school and helps second graders who are behind in reading get caught up. So find some way to plug into the community. The blue line represents the Parkinson's severity score of people who aren't lonely. The red line is the Parkinson's severity score of people who are lonely, if that tells you anything. So that's kind of where I want to end this. I'm going to make this list of resources available on the organization's website. These are a whole bunch of links that are all related to additional, deeper information about nutrition and Parkinson's disease. Brian Grant Foundation has a lot of really good recipes on their website. I suggest going there. That's probably the best website I've found so far for really kind of taking the data that I just presented and helping you answer the question, what am I supposed to eat? And so that's where I would send you for that kind of information. And this is just kind of the summary page. I'm out of them now, but I made a couple hundred of these pictures where the fast, slow rate of progression and this list of foods over on the right. And I turned them into refrigerator magnets. And for the last couple of months, I've been giving them to all my patients so that every time they go to the refrigerator, I'm haunting them with what they should or shouldn't be eating. And they have this reminder every time they open the refrigerator door. So this is the summary slide, and I'm open to any questions.
Okay, thank you so much, Laurie. That was amazing.
Yep.
So hopefully our audience is getting a sense that you know, there are a number of providers in the universe out there. You know, we like to think of it as a multidisciplinary team, and as you know, Laurie was talking about how she tends to be sort of in this gray zone between the naturopathic community and the standard movement disorder MDs. I think I'm sort of entering that gray zone, or have been in that gray zone possibly as well. And I think you know that I've been studying some yoga, some mindfulness, took my integrative medicine boards, and have been going to some meetings. And Laurie and I both presented some of this information at the American, it was the Integrative Health and Medicine Conference in San Diego. And we're able to chat with a number of like-minded colleagues of all sorts who are sort of straddling both of these worlds. And it was a lovely conference, I think. Met a number of colleagues of Laurie's in the naturopathic world, and you know, a lot of different types of doctors around the community, around the world, who are coming together, trying to put our heads together to figure out what works the best for our patients. And so I think keeping an open mind, taking things though also with a grain of salt. If somebody's trying to charge you a lot of money to treat you with something that hasn't been, you know, studied very well, I think one has to worry if there's things that are potentially harmful in this world. You know, if you're going into a clinic and somebody's trying to offer you treatments with things that are, you know, possibly harmful, you know, without a good sort of sense that they're going to help you, then I think you should definitely bring this sort of information to the attention of your treating physician and discuss this. I think what we really hope to do is start a dialogue between these different communities of providers, and have a sense that we can share ideas, that we can have our patients not hide treatments in one world from the other world and possibly get into harm. There are, you know, certain things like herbs and other treatments that we might be offered from providers, the traditional Chinese medicine provider, for example, that may actually conflict with some of the medications that we give to our Parkinson's patients. And so I think we, you know, as Western trained doctors, so I think dialogue, communication is really the key. So that's sort of what we're trying to bring to you here in this forum. To sort of the take-home points that I see from Laurie's slides are, you know, really echoing again what Dr. Duda also had talked about in his talk. Is a lot of this is in the Mediterranean diet as well, some of the nuts and seeds, the healthy oils and fats, looking at as many fresh fruits and vegetables as you can eat. And we know that that's not always possible for many of our patients. I take care of a lot of veterans, some of whom are, you know, don't have the funds to buy things at a farmer's market. And so I think we're trying to get an understanding of what might be accessible even at something like the 99-cent store for our patients, or at, you know, a VA, a canteen or something like that. So we understand that these aren't always easy things to adopt, but I think as a community, we're trying to put together a set of resources to help guide you. And if you do have the resources, hopefully to where you should spend your time, energy, and money to try to make yourself as well equipped to handle the symptoms of Parkinson's and possibly affect the progression, is really what we're talking about. I think Laurie showed a little bit about this, but exercise is something that we also all believe, I think, in as medicine. Laurie, do you want to speak a minute to what some of your findings were in the CAM PD study from an exercise perspective?
Yeah, so that is actually fascinating. So two things that I want to drive home. In terms of where we start to measure a real meaningful difference, the first 2 days a week of exercise seem to not make a whole bunch of difference in terms of slowing progression. As a clinician, I would tell anyone in my office, anything is better than nothing. I would rather you do 2 days than nothing. But from a statistical perspective, it really starts to count when you get to 3 days. And 4 is better than 3, 5 is better than 4, every day a week. And we asked the question, on how many of the last 7 days did you do at least 30 minutes of exercise? And so what we see is more is better. And the real benefits seem to become most apparent around 3 days a week and up. So that's one finding. And then something I don't think I've said out loud yet is this summer before the World Parkinson Congress, we reanalyzed the data and we looked at what type of exercise is best. And I was really surprised by the results. The top 4, the first 2 were aerobic and the second 2 not at all. And so the first 2, the form of exercise that was associated with the slowest rate of progression, and this is after adjusting for age, gender, year since diagnosis, and income, where running was number 1. The Parkinson spin classes, where you do 80 to 90 rotations per minute, was number 2. Rock climbing was number 3, and yoga was number 4. And the rock climbing was the mind-blowing one for me. I didn't know that many people with Parkinson's were rock climbers, let alone that it would be enough to make itself apparent on the data. So anyway, when I kind of think rock climbing, I kind of think of as like vertical yoga, right? It's mindful, you're thoughtful, there's a ton of body awareness stuff happening. And so You know, anyway, I just found that absolutely fascinating, but those were the top 4 for where can you get the most benefit over time.
Cool. And then, yeah, just I think a word on that. So some sense of that might be that, just looking at that data that, probably if you're able to physically exert yourself and get your heart rate up with the running and things, that maybe, a relatively milder population that's able to really run and possibly even rock climb. So I think from a safety perspective, might not be the most, going actually out to the rocks are probably
Gym,
not.
I think most people are doing gym climbing.
Doing it in the gym with supervision, definitely. But I think it's exciting that yoga's in there, because I think yoga, in my view, can be practiced at all stages of disease. And I think you get a lot of the breath work, the mind body stuff, some meditative aspects. So I think that's very exciting to me as somebody who's been a big yoga kind of advocate. So really cool. And I think, to echo the loneliness thing, I think, participating in these support groups as best you can, getting out, volunteering, getting to the local support groups that I know Sarah and her team are arranging all over our community. And if you're in other parts of the country, really trying to connect with other people, patients, neighbors, anyone in your community. Really so underrated and understated by us in the medical community, but I think makes a huge difference. And just in the aging literature in general, there's a huge amount of literature now about prognosis, if it's even is in normal age, healthy aging, for our caregivers out there who are isolated. Being socially isolated or lonely is as bad for you as smoking on a regular basis is bad for you. So I think we really want to think about this as a social determinant of health that we are not speaking to. And ultimately, we're social animals. We're humans. We need the human touch. We like to hear and hear voices, see each other, and be present. So I think anything you guys can do to get that to happen is really important. And so what we've been telling people is, if you can grab a friend, go for a walk, and have go to the farmer's market and get some salad ingredients, and come home and cook for each other, and possibly share a glass of wine with conversation. I think this is the type of thing that in a lot of the blue zones and a lot of the Mediterranean environments that are happening daily, that we are probably in our North American community is possibly missing out on. So really want to emphasize that. So I think there's a few questions that have come in through the chat. We can maybe take a look at some of those. There's been,
let me just answer the one about glutathione. Is it available in intranasal form? The answer is from compounding pharmacies, but the short answer is no. It becomes very expensive. There is a compounding pharmacy that we use here in Washington that has the same one that supplied our studies. But it ends up costing over $350 a month. It has to be stored in the refrigerator. It is actually, it's inconvenient. It's hard to find a place to lie down and snort it. Based on my research, several companies have made an over-the-counter intranasal glutathione, and you can get it on Amazon. Given how hard it is to keep the high quality pharmaceutical grade stuff stable, I have no confidence that the stuff you're buying on Amazon is in good shape by the time you get it. And I personally would not advise snorting it. That's not the same product or way that the study was done. So we are working on a way to find a way to deliver it intranasally, but short of working with your physician and a compounding pharmacist, the short answer is no.
There's a question here about N-acetylcysteine. I don't know if you want to talk.
So the reason people do N-acetylcysteine research is with the hopes of boosting glutathione. And I think it really does work for a couple months. I mean, for short term, what happens is, so glutathione is 3 different amino acids: cysteine, glutamic acid, and glycine. So what happens is, while your body has some of these amino acids, you put a bunch of cysteine in, and you will make more glutathione. But what will happen after a couple months is you actually run out of those other amino acids. You can't just put more and more cysteine into the mix and think you're going to have an endless supply of glutathione. There is no data anywhere that says cysteine is low in people with Parkinson's. There is a ton of data that says glutathione is low. So really, it makes no sense to me to take cysteine without those other two amino acids. And it's really not any cheaper to take N-acetylcysteine than oral glutathione. So I just tell people take straight glutathione. But I'm aware of the research in the short-term stuff that does show it boosts glutathione. That's exactly what we want. In our CAM care data, people taking N-acetylcysteine are actually, it wasn't statistically significant, but glutathione was associated with slower progression over time. N-acetylcysteine was associated with faster progression over time. And again, the glutathione was statistically significant, the N-acetylcysteine almost. So based on kind of the picture that is starting to emerge, I say just take the glutathione if you're looking to supplement with something along those lines. And guess what? 2 studies show that yoga increases glutathione. Makes no sense to me. I don't understand how that works, but it has been replicated, and there is good data that says yoga, an 8-week yoga class will improve glutathione levels.
Interesting. So there's a couple questions on exercise here. So you talked about the types of exercise. So when we're talking about intensity, so you said every day. How long, do you have a sense of how long and how intense?
Not really. The way we ask the question is, how many days have you done at least 30 minutes of exercise? So I can't tell you whether 2 hours is better than 1 hour, but I can show you that 7 days is better than 6, 6 is better than 5, 5 is better than 4. And even go for a walk. I mean, even if you want to take a day off from the gym, at least get outside and go for a 30-minute stroll is what we're getting at here. You don't have to, I'm not suggesting that you never give yourself a break. And we're just saying, try and make physical activity a part of your daily routine.
Okay. There's also been some questions about swimming and water things. Was there any data that you had on that, or?
We asked about swimming. It was not statistically significant. And again, when we say it's not statistically significant, we don't know if that's because not that many people are swimming or because it's not making a huge impact. The data doesn't allow us to know what we're talking about.
So I think from an exercise perspective, our thoughts would be probably similar, is that if you can get an hour a day of something that you love to do, if you can make it a social situation, going for a walk with a friend or going to a group class, I think we're very, I think those are reasonable approaches. Again, if you have a lot of motor issues, the safety aspects would definitely be important to address. So I think those are sort of a sense of things.
Does everyone here know The Daily Dose with Nate Coomer? So this is something I recommend for all of my patients. It is cheap, it's free for the first month, and $29 a month after that. And every single day he posts a new workout designed for people with Parkinson's. He is one of the best physical therapists in the world, and it is Parkinson specific, and he's got dual task stuff in there. There's cognitive stuff mixed in with there. He makes you frustrated. He makes you mess up, and everything you're doing, he does a great job teaching you why what he's asking you to do is so important for Parkinson's. So the website is dailydosepd.com. And if that's, especially for people who have trouble getting to exercise classes and don't have a community, don't know where to start, that is a brilliant place to start. Even if you do the first free month, you will get something from it.
And just plugging the physical therapists, I mean, I think that they are another part of the team that is hugely important. We work with a number of them. There are Parkinson's, actually, physical therapists out there. I know I was just at Becky Farley's gym with the Power Gang last week. Really some amazing people who have taken time, built careers. We have some folks in Southern California, Encourage, Reactive, a number of gyms out here that are really just amazing physical therapists that have really taken the time to understand the disease and are trying to make Parkinson's specific recommendations in the physical therapy world. So I think if you have very little activity at this point, getting a consult from a physical therapist, seeing where to start, weekly, maybe 8 weeks or 10 weeks of physical therapy, and then drawing out a program that can then define how you do it would be a starting place. And I think, more is more in this sort of universe of exercise. I think, trying to get a daily prescription of something like that in. Laurie, I had seen a prescription that you had made, I think, on one of your Facebooks about, so you talk a little bit about nutrition in that, the exercise we've touched on, social isolation. What else is in the prescription? I think sleep, right?
Sleep,
What's
and
your sleep recommended?
get it, do it, protect it like your life depends on it. You know, I think that I have kind of a whole package I do with people that goes everything from making sure you exercise and not drinking alcohol before bed. Caffeine can really, really mess up people's sleep more than I think people realize. So we talk about sleep hygiene. There's a fabulous video by Dr. Jason Valerio, is up at University of British Columbia, and he's board certified in, he's a movement disorder specialist who's board certified in sleep medicine. And I make a lot of patients watch his 1-hour video on sleep. I think it's fabulous. He talks everything from tips and tricks to sleep hygiene. I do think melatonin works really well. You have to use a fairly high dose, 9 to 12 milligrams, and it has to be sublingual. I think nothing works better to help people with Parkinson's sleep than cannabis, and you don't need to get high. I have a lot of people who will just do plain CBD in an oil or capsules, but in my 19 years of practice, I'd say nothing is more effective at helping patients with Parkinson's sleep than some form of cannabis. Those are probably my go-tos for sleep.
Yeah, and I would say I echo the certainly sleep is like detox time. So sleep's really important. We try to get 8 hours if possible of sleep if you can. I think it's really underrated. So trying to sleep. Good exercise when you're physically tired helps sleep as well. So I think that's important. Melatonin, certainly, especially if you're having REM behavior disorder, which is when people fight and act out in their dreams, is very effective. So those would be the two things that I would recommend. Haven't honestly been prescribing CBD, or I work in a VA setting, so we're really not really talking about those things. But I would say that the first two recommendations certainly from my perspective. Anything else on that prescription, Laurie? I can't remember.
Replacing deficiencies.
Okay.
And I included levodopa. I think as an alternative medicine doc, a lot of people come to me wanting to avoid pharmaceuticals. And the first thing I do is make it really clear, I don't think you're doing yourself any favors to continue to deprive your body of dopamine. It is just as much a nutritional repletion strategy. If you're deficient in dopamine, take dopamine. If you're deficient in vitamin C, take vitamin C. It just doesn't make sense to me that you would deprive your body of something we all agree you don't have enough of. And then, along those lines, there's another question about supplements. I mean, I really try and make that individual. I do lab tests, and kind of, if a person is deficient in vitamin D, I'll prescribe vitamin D. I don't kind of have a one-size-fits-all package that people can take. I will say, and I've not said this publicly yet either, but there were 4 supplements that were associated with slower progression over time, and it was glutathione, CoQ10, fish oil, and turmeric/curcumin. I would still say, don't just start spending money on stuff. Talk to your doctors about this. 50% of what is sold over the counter doesn't even have in it what the label says it has in it. Quality control is a big problem. And, if you're on warfarin and taking fish oil, that makes a difference. I mean, these aren't all cheap supplements. The side effect can be financial, and it can interfere with other meds. So even though I don't mind sharing those data, the reason I don't put them on the handouts is because I don't want everyone running to the supplement store and just taking them, because these are medicine like anything else, and you should have some guidance when you decide to start something new.
Can you repeat that? I think people want to know the supplements again. So you said fish oil, Laurie?
Mm-hmm.
Fish oil? Say the 4 again. You said it pretty fast. I think people are asking.
Glutathione, fish oil, coenzyme Q10, and turmeric/curcumin.
Okay. Sounds good. So there are a few more very specific questions. All right, there's a lot of specific questions here. It might be hard to generalize. Let's see here. So there were some questions about dairy in general. So you tell people to I know it's controversial. I know John Duda, who was on, is a vegan and really talks about vegan diets, and so avoiding dairy and meats in general, and even fish he tries to avoid. So, but it sounds like you're no, not really a
I
proponent of
mean,
dairy.
it so I like good cheese as much as anybody else, right? I think this, and Dr. Duda is he's a good friend of mine, and he's much more personally strict than I am. I'm a little bit more of the B+ is good enough type of person. He's a little more structured and philosophically committed to a certain way of eating. What I will say about dairy is it is mind-blowing to me, people's resistance to dairy. When I tell people that vegetables and beans and nuts and seeds are associated with slower progression, nobody argues with the data. When I tell them that fried foods and soda and are associated with faster progression, no one argues with the data. As soon as I say dairy, people start questioning the whole study, right? And we have now done 6 studies globally where we follow people for 30+ years and ask, is there anything in our environment that could be causing Parkinson's? Well water, head trauma, certain work environments. Every one of those studies has identified dairy as a risk factor for developing Parkinson's disease. Some studies say milk, ice cream, and cheese. Some say yogurt and ice cream. Some say, depending on how the study was written and in which country they asked it. But very consistently, dairy comes up over and over and over as associated with the more dairy you eat, the more likely you are to get Parkinson's. My data says once diagnosed, the more dairy you eat, the faster it progresses. Like, I can't understand people's insistence on continuing to find a way to eat dairy. Like, oh, but I do grass-fed, I do organic, I drink Lactaid, so mine doesn't have lactose in it. People have so many schemes and loopholes and strategies for trying to find a way around that data point. So yeah, especially in this day and age, when you can go to our local Fred Meyer and get 17 different dairy alternative milks. There's hemp milk, soy milk, rice milk, cashew milk. I mean, there are so many alternatives these days. I would say just learn to eat dairy-free.
Okay. So another question. One is about gluten. What's your thoughts on gluten?
So there's no question that over the course of a week, I will meet at least 2 people who tell me when I quit dairy, my heartburn improved, my hemorrhoids went away, my fatigue improved. I think that gluten.
Gluten. Okay, you said dairy. Okay.
Yeah, gluten.
Yeah.
And so I think for whatever reason, fatigue, heartburn, and hemorrhoids tend to be the most common things that people tell me that they notice when they give up gluten. Whether that is placebo, whether that is real, I mean, there are only about 5% of people with Parkinson's actually have celiac disease. There's a lot more coming out about gluten molecules, some of the ways that the treatment and glyphosate and some of the stuff that we're using in the production of gluten, increasing intestinal permeability. There's something called zonulin that kind of holds your stomach lining together, and wheat has been shown to kind of loosen that up and make for what we call leaky gut. And so it might be that it's not a celiac thing, it's not an immune system thing, but it does cause intestinal inflammation for some people via another route. So I'd say there's a lot of disconnect between what patients believe or are experiencing and telling me and what is published about gluten. There's very little in the literature that would suggest gluten is bad. In fact, I think it's a really great source of fiber for a lot of people. And if I'm taking away your dairy, your beef, your soda, all this other stuff, I mean, why complicate things more than it needs to be? To now throw away gluten can really be complicated for people. And so, but like I said, I just had somebody this morning who told me that, as soon as she quit gluten, her hemorrhoid she had battled with her whole life disappeared. And there's a bunch of really neat research coming out about how intestinal inflammation causes production of alpha-synuclein, right? And so, we didn't know, if you ask people, why does the human body make alpha-synuclein in the first place? It was just 2 years ago that researchers in the Midwest someplace showed that this is the first thing we've learned about why humans make alpha-synuclein, and it is in response to intestinal inflammation, right? And so I think I think more and more we're learning that the gut holds a lot of answers that we haven't even begun to unpack and unravel. But on a more global perspective, if you don't feel better when you take something away, and you have no reason to believe that it's causing you a problem, no doctor has told you that you have antibodies to this food or, you know, something like that, don't make your life more restrictive than it needs to be.
Fair enough. Um, yeah, I mean, I think what we're trying to do is give general principles. We don't want to handcuff anybody and torture people all day long, telling them all the 50 things that they can't do. I think you need to try your best to follow these global recommendations. And I think the wellness stuff like sleeping, eating healthy, balanced meals, hydrating, take exercise, moving around, trying to stay active, trying to stay mentally active, socializing. These are general principles that we want to try to bring to you. And I think what Dr. Mischley is also saying is that she truly believes, and I think we've worked together well in this universe of believing that using levodopa or Parkinson's medication to help motor symptoms is a way to help you get to feel like you can do these other things that we want you to be doing. So it's not that we are trying to keep people off of medication. I think one take-home message is if you're going to a doctor that's trying to get you off of your medicine or keep you off of medicine, that would not be our strategy. The hope is to try to use these things to hopefully delay the progression. And we don't have good data to show that. We have clear, ways to change the course of disease, but these are things that seem to prognosticate better if you try to incorporate them in your day-to-day lifestyle, which is something that I don't think you're probably getting the message from your regular, Western trained doctors. So one last question, maybe we have like 3 minutes left. So I do want to have a chance to close. There's a question on CBD oil and sources of good CBD oil. I know from my perspective, it's hard to know what you're actually buying from many of the dispensaries. And I know where we both practice, things are, legal, and medical marijuana has been out for a long time. But even my sense is that there's not really great regulation no matter where you get this stuff.
Well, not only is it poorly regulated, but hemp is considered like a cleaner crop, and it actually, like if you have like a waste dump and really toxic soil, you can plant hemp, and the hemp plant will suck all the toxins up out of the soil into the plant. And so it is more important than most things to actually know where you're getting your source from. They use a lot of nasty chemicals to extract it. And then the other thing that is a little confusing, but the non-psychoactive CBD, you don't get high, right? THC is the chemical that makes you high. At least in Washington, and I believe this is true in most states, CBD is more expensive than the THC. And so it's really hard because the stuff that doesn't make you high is harder to come by, it's dirtier, and it's more expensive. So what a lot of, because we have regulations and good laws here in Washington, you can actually go to the cannabis dispensary and everything is tested for pesticides, you know what you're getting. And what a lot of my patients will do is there's some science that says if you add just a little teeny bit of THC, not enough to get you high, but you can add a little teeny bit that will make the CBD work better. And so a lot of companies or a lot of my patients will find they needed 20 milligrams of CBD to sleep, or they can do 5 milligrams, 10 milligrams with 1 milligram of THC. And so still, that's not enough to get high, but it is enough to make the CBD work better. And frankly, it just saves $40 a month. And so that's why a lot of people will do it that way. There is a company, probably the first pharmaceutical grade over-the-counter product is, there's a company called Douglas Labs that makes a very, very high quality CBD product. It is not cheap. It's probably $80 a bottle, $100 a bottle. It's not cheap at all, but that is the most reliable source I have ever seen in terms of where it's coming from, what they're putting in there, who they're shopping with. So, but I don't know that you really need to go to the fancy high-end CBD, but I would say clean is important. Ask the supplier where it's coming from, and if it's possible to get the clean stuff, I would do that.
Okay, well, this has been really amazing. Thank you so much, Laurie, for joining us. And we may have Laurie back next year, depending on what we're hoping to get sort of feedback and topics, future topics from the audience, and hope that we can continue to bring you quality, information. And, not everything that's shared here is going to be what every doctor thinks, or necessarily even Laurie has a lot of her own personal sort of favorites and anecdotes and information, and so take it with a grain of salt, but it's, I think, communicating, having a sense of taking this information and bringing it to your doctor so that people are able to know what everybody's doing, what you're putting in your body, is very important. So thank you so much, Laurie. And I don't know if anyone from PMD Alliance wants to close, but thanks to PMD Alliance again for giving us a forum to bring you this kind of offering.
And thank you for hosting this and starting this whole thing and bringing this together. It's a conversation that we need to be having, so thanks.
Yes, thank you to both of you, Dr. Subramanian and Dr. Mischley. I wrote down so many notes and I was watching all of the chat comments. I think aside from CoQ10 dosages, what Dr. Subramanian said, go to the farmer's market with a friend, laugh, get your heart rate up, smile. That sounds like the best and the easiest takeaway, and it's data-backed, research proven. So thank you so much for sharing that with us, Dr. Mischley, and thank you for being our physician moderator, Dr. Subramanian. And I always like to close, so a lot of you have had your video off. So I always invite us to turn our video on. In the bottom left corner, you can start your video. And then in the upper right corner, you can switch it to gallery view. And that way we can all see each other's smiling faces. And if you learned something today, wave like a crazy person. I always like this part. So thank you all for joining us. I hope you learned something, smiled. Again, the recording will be on YouTube. Give us by the end of the week, and the downloadable slides. If you email us, if you want that, email us at info@pmdalliance.org. There's a ton of great resources on there that I'm sure everyone will want to refer back to. So thank you, everyone. Have a great day.
Thank you.
Take it easy.